Okay, I believe we can start. It's 12 a.m. here in Milano, and this will be the beginning of the first COVID-19 webinar series held by Dräger. Just a small disclaimer. This webinar presentation is for information purpose only and has no commercial background. Dräger has neither influenced the content of the presentation nor taken editorial measures. The sole responsibility for the content of the presentation and the webinar lies with the author, and all views expressed or information given are those of the author and are in no way attributable to Dräger. Before we start, just a small reminder that the webinar will be recorded and the recording will be distributed afterwards. You can find here on your user interface the possibility to raise your hand, and I would like to ask you if you can hear properly my voice to raise your hand so we can check that everything is fine. Very good. I can see the numbers growing. Thank you so much. And you can also raise your question during the presentation using the question field. The question will be answered by the host at the end of the presentation. And I'm really, really happy to welcome you finally to our first webinar. And the title of today's webinar is COVID-19 Patient Characteristic in Italy, Lesson Learned from the Lombardy Experience. My name is Emilio Carmignotto, and I'm the Responsible Marketing Manager for Respiratory Care in Dräger in region Europe. And this is the first COVID-19 webinar series organized by Dräger in order to spread knowledge on this topic. Be aware you will automatically receive a copy of today's slides and the link to access the recording, but please remind this will happen only if you clicked on the opt link in an email that you have received when you register for the webinar. This is for privacy reasons, so in case you didn't do that, you can also do it right now. Just remember to click on the opt-in. And this is the first webinar of a series, and you can find more in regards of the next webinar in the next weeks following the link or the QR code. And it's my pleasure now to give the possibility to our host today, Professor Giacomo Grasselli, that will present the webinar. Giacomo Grasselli is Associate Professor of Anesthesia and Intensive Care Medicine at the University of Milan, and he is the Medical Director of the Intensive Care Unit of the Ospedale Maggiore Policlinico in Milan, and you can find all the details here. So I will now switch to Giacomo. Thank you, Giacomo, for your presence.
So, thank you, Emilio. Thank you all. Can you see it?
I can properly see that.
Okay,
so
perfect.
I can see you and the presentation. Thank you.
Thank you. Thanks, Emilio, for the introduction, and thanks everybody for attending this webinar. I have been asked to present you basically what happened in our region. As you know, Lombardy has been the epicenter of the first huge outbreak of COVID-19 in the Western world. And I was responsible for the creation of the ICU network in our region. And so I will show you what we learned from this experience in terms of organization and in terms of patient characteristics. I will not go deep into the story of ventilation management of these patients, because you have 2 webinars on that in the future. But of course, I will be happy to take any questions about mode of ventilation, ventilatory management, or other aspects of the management of the patients. So just to start with a curiosity, as you can see here on the left-hand side, the usual epidemiological curve of seasonal flu that usually has a peak during the first weeks of the year and then goes back to baseline. While this year in Lombardy, the curve had a different shape, and you see here that around end of January it didn't go back to baseline but just stayed up, and this was due to a growing number of cases of COVID-19 who were initially misdiagnosed as seasonal flu. So this tells us that probably the disease was around in Lombardy and for at least a couple of months before the first case was diagnosed, and we are trying to demonstrate that also with a dedicated study. Anyway, the first patient was diagnosed on February 20, as we will see. On March 11, WHO declared COVID-19 as a pandemic. Italy immediately became the second most affected country in the world after China. Now, the United States, as you know, have the highest number of patients, but Italy still ranks very high in the ranking. We still need a lot of information about the clinical characteristics of the patients admitted to ICU. We know that the proportion of patients admitted to ICU is different in different series. It ranges from 5 to 30% in the published studies, and clearly a better knowledge of the clinical characteristics of the patients, of the factors associated with outcome, is extremely important for the healthcare system's preparedness. So this is what happened in Italy, basically. This slide is updated on June 3 and comes from the infographic of the Istituto Superiore di Sanità, which is our National Institute of Health. You can see that in Italy we had something like 234,000 cases of COVID-19 with more than 30,000 deaths, and a high number of infections among healthcare workers. The median age of cases is 62 years, and on the right-hand side you can see the curve. So we had a peak around mid-March, and then luckily enough an important decrease in the last weeks. And here you can see our country and the regions most affected, which are Lombardy, Veneto, Piemonte, and Emilia-Romagna. So basically the northern part of Italy. While here you can see mortality in the different age classes. I'm showing this because, as you know, mortality has been discussed a lot, because if you look at the number of total deaths compared to the total number of infections, you would say that the mortality rate is quite high in Italy. Well, this is probably not completely true. And in this paper in JAMA, Onder and other people from the Istituto Superiore di Sanità discussed the issue of mortality in Italy. And we can say that probably one factor affecting mortality is certainly population age, because if you look at the mortality by age classes, you can see that in Italy and in China, it's exactly the same up to the age of 69, while it increases a lot after the age of 70, and Italian population is certainly older than Chinese. Then we probably have an issue with the definition of COVID-19 related deaths. And the most important factor affecting mortality is certainly the testing strategy, because at least in Lombardy, it was basically impossible due to the very high number of patients infected at the moment of the first diagnosis. It was really impossible to do a very aggressive contact tracing strategy. So we ended up testing only heavily symptomatic patients. So probably the number of cases has to be subdivided over a much larger denominator of infected cases, because we missed, certainly, at least during the first weeks of the epidemic, we certainly missed a huge number of asymptomatic or patients or of subjects with very little symptoms. So we published a viewpoint in JAMA describing our experience with the organization of the ICU system in Lombardy. This has been published together with my mentor, Professor Antonio Pesenti, and with Professor Maurizio Cecconi, who is the president-elect of the European Society of Intensive Care Medicine. The first patient was diagnosed on February 20 in Codogno, which is a small village, a small city south of Milan. And we were very concerned because, first of all, because this patient was quite young, and this was not expected based on the case series coming from China. And the second, probably more scary problem was that on the following day, 24 hours after the first diagnosis, we had 36 new positive cases who were all unrelated to the first patient. So it was immediately clear to us that the number of patients infected around must have been huge. And so we had to decide how to organize our ICU network. The pre-pandemic ICU bed capacity in Lombardy was around 750, 800 beds, accounting for less than 3% of the total hospital beds. We established an emergency task force in the region, in the government of the region, and then we decided to create a network of dedicated COVID-19 ICUs. So we decided to cohort the patients in dedicated units, physically separated from the rest of the ICUs in the hospitals. And we started with a network of 15 COVID-19 ICUs in 15 hub hospitals that were basically hospitals with an infectious disease department and with a pneumology department and an ICU with experience in the treatment of acute respiratory failure. So this was our start. These are the epidemiological forecasts of the number of ICU beds that we expected to have 1 month after the first case, assuming both a linear or an exponential growth. And this is what basically happened. So luckily enough, we had a linear increase in the number of cases and not an exponential increase in the number of cases, because otherwise we could never be able to cope with this forecast. The fact that we did not have an exponential increase but a linear decrease was due to the start of severe lockdown measures and restrictive measures in the region first and in the entire country immediately afterwards. So what we did, we've been able to increase our ICU capacity by about 1,000 beds. So we went from 750 to almost 1,800 beds. This network of COVID-19 ICUs had a central coordination, and I was the responsible for this coordinating center. And the central coordination was very important because we were able to allocate, hopefully to properly allocate every single patient, So we had, let's say, a real-time assessment of where we had free beds and where new patients could be admitted. To give you an idea, around mid-March, we had something like 150 new patients every day in the region. This increase in the ICU bed capacity was made possible by stopping all elective procedures, surgical and non-surgical, and by a huge reorganization of the entire regional hospital network, because we tried to concentrate all the time-dependent diseases in a limited number of hub hospitals. For example, for major trauma and neurosurgical emergencies, we identified only 3 hubs in the region. And so all the patients with major trauma were transported to one of these 3 hubs. And this allowed us to free a lot of space, a lot of units. For example, a lot of neurosurgical ICUs that were converted into COVID-19 ICUs. And then also we used the operative theaters as ICUs. But again, the most important thing were the containment measures that were put in place by the government. This is how the number of patients changed over time. You can see that at the peak, we had something like 15, sorry, I think I have an updated one. So we had 1,511 patients on April 2nd. And then the number of patients started to decrease. As you can see here, we started from, as I told you, we started from 15 COVID-19 units, and we ended up with 95 COVID-19 units in 72 hospitals. So our initial decision to concentrate those patients in hub hospitals was made impossible by the huge number of patients. In 3 months, we have admitted to our ICU something like 4,500 patients, of whom 2,500 have been discharged alive, 1,900 died, and a little number of them, like 120, are still in ICU. But the next slide, I can show you that basically the number of beds in the last days is constantly but slowly decreasing, and we barely have any new admission. And now the new admissions are basically of patients who are not admitted for acute respiratory failure due to COVID-19, but of patients who had other diseases and incidentally test positive for COVID-19. So the patients are changing, and luckily enough, also the number of patients requiring ICU is steadily decreasing. So what we learned was described in these messages that, together again with Maurizio and Antonio, we published on the European Society of Intensive Care Medicine website. Take-home messages were that a COVID-19 outbreak is characterized by a huge mismatch between the number of patients requiring ICU admission and the available ICU beds. So if you have to face a COVID-19 outbreak, you certainly have to increase your ICU capacity. And our model of establishing a network of dedicated units with the central coordination, from my point of view, was quite successful. Clearly, protection of healthcare workers is extremely important. So healthcare workers must be trained on the proper use of personal protective equipment, and probably even more important, availability of enough personal protective equipment is extremely, extremely important. And we also tried to define protocols for triage of the patients and for the treatment of COVID-19 patients, because as I told you, since we had to move from a model that were based on a limited number of hubs to a model that basically involved all the hospitals in the region, then at a certain point we had to to admit patients with COVID-19 ARDS, not only to ICUs with experience in the treatment of ARDS patients, but also to smaller units with less experience. And so we tried to homogenize the treatment protocols. And so we gave sort of common protocol, at least for the ventilatory management and for the pharmacological management of the patients. In the second part of this presentation, I will tell you something about the clinical presentation and the clinical characteristics of our patients. These first slides are very generic. We all know that COVID-19 patients present with systemic and respiratory manifestation and get that fever, cough, fatigue, and shortness of breath are the usual signs and symptoms. There are also less common and rare symptoms, but what is very important is that there is a certain number of asymptomatic individuals that act as carriers, and this is probably the more important point of from the epidemiological point of view. This is the classification of the Chinese CDC that subdivides patients with mild disease, who are patients with non-pneumonia, which are the majority, of course, patients with severe disease, so patients with pneumonia and a certain level of hypoxemia, and almost 5% of the patients have critical disease, which is respiratory failure, ARDS, and multiple organ failure. And here you can see the distribution of the frequency of the different severity of presentation in Italy for 50,000 cases. And you can see that, again, critical cases are around 5% of the total. The radiological presentation is quite typical, both on the chest X-ray and on the CT scan. So we all know this, and there are a lot of good papers published on that. This is our data that we published in JAMA about 1 month ago. This is the first paper in JAMA on the first 1,500 patients. Then I will show you at the end of this presentation some new data that are still unpublished, but are, I hope, on a good way for being published. So this first paper was done on 1,591 patients with confirmed COVID-19 admitted to our Lombardy ICU network. So the data were recorded on an electronic worksheet during daily telephone calls because people from the coordinating center of the ICU every day used to call every unit to know the number of patients admitted and some basic clinical characteristics of those patients. And we recorded at admission age, sex, comorbidities, mode of respiratory support, use of ECMO, and prone positioning. And then something about outcome. So age is, gender is a very important demographic data because, as you can see, in the overall population, the disease is more frequent in males. But when we move to critical patients, this difference becomes huge. So male have a higher risk of infection and a much higher risk of developing severe disease. Age is another important risk factor, as we all know. So in our patients, this was the age distribution. So the median age was around 62, 63. So half of the patients were older than 60, and almost half of the patients were younger. And we also had a certain number of young patients and not very young patients. But basically, most of the patients were older than 50, and a good proportion of them was older than 60. Almost 70% of the patients had at least one comorbidity. In this work, we did not we did not have data about BMI, so I cannot tell you how many of those patients were obese. But I know that 70% of them had at least one comorbidity, that the most frequent comorbidity was hypertension. Half of the patients were hypertensive. And then other cardiovascular disease and dyslipidemia, while only a small percentage of patients had COPD, a history of COPD. What about respiratory support? So I'll say that like almost 90% of the patients were intubated at ICU admission, because one thing I didn't tell you, but it's very important, is that we, as intensivists, we had to take care of at least the same number of patients admitted to the ICU who were assisted with some form of non-invasive respiratory support in the wards. So, for example, on April 2nd, when, as I told you, we had the highest number of patients in the ICU, around 1,500, there were something like 2,000 patients in the wards on CPAP or non-invasive ventilation that we had to take care of. So we basically admitted to ICU almost only patients who needed, who were intubated at admission. Around 30% of the patients were prone during the first days from admission. These are the data of ECMO support in the first 1,600 patients, but also in the entire population of 4,000 patients, the number of ECMO runs has been really limited. With regards to respiratory mechanics, you know that it's a very debated point. I have to say that some patients were characterized by a certain mismatch between a relatively good compliance of the respiratory system and an important impairment of oxygenation. So I cannot say that all the patients had high compliance, but a certain proportion of the patients had high compliance. And in another work that we are that it's under review now in a major journal, we compared our case series with the database from two very large ARDS conventional, let's say, or usual ARDS database, and we see that the patients with COVID-19 have a wide range of compliance of respiratory system. So some patients have very low values, but the majority of the patients have tend to have a compliance value which is slightly higher than that measured in conventional ARDS. I can tell you that the average value of compliance in our population was around 40 ml per centimeter of water, and was not basically did not change among patients with mild, moderate, and severe impairment of PF ratio. So patients with relatively high compliance clearly have low plateau pressure and low driving pressure. We basically applied in every patient a protective tidal volume. So in our population, I think that the average tidal volume was around 6.5 ml per kilogram of ideal body weight. And another typical characteristics is quite high ventilatory requirement. So those patients needed to be ventilated with high minute volume because of increased dead space. So these were the values of those first 1,600 patients published in JAMA. The median and mean PEEP level were around 14 centimeters of water. The median FiO2 was around 60 to 70%, and the PF ratio was around 150. So the majority of the patients had moderate ARDS and required relatively high levels of PEEP. I have to tell you that during in time, those patients were admitted basically from February 2nd to March 8th. Then in the following weeks, while we learned more about the pathophysiology of the disease, we tended to decrease the PEEP level. So in the entire population of 4,000 patients, the median PEEP level decreased from 14 to 10 centimeters of water. So this is how changed our typical setting of ventilation over time in the region. So these are data on mortality. Clearly, when the paper in JAMA was published, almost 60% of the patients were still admitted in ICU, and that's why we did not want to provide outcome data, but the editors really wanted us to give some outcome data, and so mortality in this population was 26%, but it was again certainly underestimated because a huge number of patients were still in the ICU. Anyway, you can see that mortality increased almost linearly with age, and it was like very high after the age of 70. And this was the ICU length of stay with a minimum follow-up of 15 days, and you can see that the length of stay in the ICU was around 8 to 9 days for patients who died in the ICU, but it was much longer, like 16, 17 days for patients still in the ICU. Then I will show you 3-4 slides of new data that again have not been published yet, but are updated information. So we followed up those patients, the entire population of 4,000 patients and the subgroup of 1,700 patients with a definite ICU outcome. And you can see here that this is the actual ICU and hospital mortality of the first 1,700 patients. So basically half of the patients die in hospital, half of critically ill patients die in hospital. So the 26% mortality that we published in the first JAMA paper was certainly underestimated again. And while you complete the follow-up of those patients, you can see that basically more or less half of them die. And this is in line with other published data, or even slightly lower mortality, taking into account that almost 100% of those patients were intubated and non-invasive mechanical ventilation. Again, this is updated information about outcome. You can see that, again, male die more than women, and that the median age of dead patients is 65 years versus 59 in patients who've been discharged alive in the ICU. And you can see that hospital mortality is slightly higher than ICU mortality. So another 5% of the patients die in hospital after being discharged alive from ICU. And I'm sorry, this is a little bit crowded. With regards to comorbidities, again, in the entire population, 50% had hypertension, and 70% had diabetes, 11% malignancy, and again, a small percentage of patients with COPD. But you can see here at the univariate analysis that basically all of those comorbidities were associated with death. Then at the univariate analysis that I'm not going to show you, but I can tell you that the univariate analysis of these only age, male sex, history of COPD, and lower PF ratio and higher PEEP level at admission were independently associated with mortality. So, for example, hypertension was not associated with mortality, And another thing, relatively novel thing that I can tell you is that in the follow-up paper that we're trying to publish, we also analyzed chronic medications, and we didn't find an association with the use of ACE inhibitors or angiotensin receptor blockers and the outcome of the patients. And these are the outcomes in terms of length of stay, and you can see that again, the median length of stay in the ICU is 10 days for patients who died and 15 days, but with a wide interquartile range, as you can see, for patients who've been discharged alive in ICU, but we still have patients who have been in the ICU for 80 days. And again, the length of hospital stay is very high. You can see here the length of hospital stay in patients discharged from ICU is around 40 days, and also prolonged mechanical ventilation. So clearly, our studies have limitations. The first one is that we are talking about retrospective data. We have a certain number of missing data, because I'm sure you understand that we had to collect those data under very difficult conditions. And in the first JAMA paper, the follow-up was really too short to give meaningful data about outcome, but I showed you updated the information with a very long follow-up. And so we now know the actual outcome of the critical patients. And again, in conclusion, we know that the majority of patients were older males with at least one comorbidity, that in our case serious, at least at the beginning, we had to apply, or we decided to apply relatively high levels of PEEP, but then we moved to lower levels of PEEP in time. And again, ICU mortality was 26% in the initial paper, but the definite ICU mortality is around 45 to 50%. And this was my last slide, and I'm very happy to take your questions.
Thank you so much, Giacomo. Thank you so much. So we have already some questions. We will go through all of them, but please, if you have additional questions, feel free to input them in the question field so we can go through all of them. So the first question is, can you please comment about the use of supraglottic airway of COVID-19 patient if need?
Well, I do not have special comments on that. We used basically all our patients were intubated via orotracheal or nasotracheal, with orotracheal or nasotracheal tube, and then we tracheostomized them. In the end, I would say, I cannot say early, but most of the patients who stayed in the ICU for a long period have been tracheostomized, of course. I can't tell you anything specific about supraglottic airways. I can tell you that a certain number of airway obstruction after extubation have been reported, and it happened also to us, to a young patient, a very young patient who was extubated and had an upper airway obstruction due to laryngeal edema, and unfortunately he underwent emergency tracheostomy, but he had hypoxemic cardiac arrest and eventually died. So this was a very tough moment for us and a very serious complication. And I know that there are reports of upper airway obstruction after extubation. So this is something that we have to take care of. But I have no direct experience on the use of upper airways management with devices different from endotracheal or nasotracheal tube.
Okay, thank you. I will now go through the second question. There is an introduction, the reason of the question, and then the question. So only a small portion of COVID-19 patients get sick enough to require ventilation, but for the unlucky few who do, data out of China and New York City suggest upward of 80% do not recover. A UK report put the number only slightly lower at 66. Now the question is, causes the mechanical ventilation a higher risk as an invasive form of support, as the half of such treated patients died in the UK?
Well, this is a very important question, and I don't know if I'll be able to answer it properly. But what I know is that we basically tried to avoid invasive ventilation in every patient, because all of our patients underwent trial of non-invasive respiratory support. It was basically, most of them underwent CPAP, because and specifically helmet CPAP. You know that in Italy we really like the helmet. We also did some prone positioning in non-intubated patients in order to try to avoid intubation and also to spare resources, because as I told you, we got to a point where we really it was really difficult to find an ICU bed for every patient who needed an ICU bed. So what I know, and we are now submitting a study together with Giacomo Bellani on this issue, is that something like 30% of the patients who were non-invasively assisted failed the non-invasive support and needed intubation. Once patients were intubated, we tried to be as more protective as possible. What is true is that despite the application of protective mechanical ventilation settings, so low tidal volume, low plateau pressure, low driving pressure, a certain number of patients develop something like fibrosis. I mean, the compliance of the respiratory system in those patients tend to decrease over time. And if you take a CT scan of them, you can clearly see signs of overinflation in the non-dependent lung zones, with bulle and cystic lesions in the non-dependent lung zones. So some of my colleagues have suggested that COVID-19 is a sort of multiplicator of ventilator-induced lung injury. So what I know is that invasive ventilation in our patients was life-saving in half of them, and it was absolutely needed. What I think is that probably invasive ventilation added some damage to the disease itself, especially in patients who had to be ventilated for longer period of time with high minute volume. So I don't know if this answered your questions about the outcome. Again, it's true that patients who need invasive mechanical ventilation die more, and this is probably because they have a more severe disease. There are studies showing a mortality of around 90% of intubated patients. Our data are more similar to the UK data. In the last ICNARC report, I think that the mortality was around 45–46% ICU mortality, so similar to ours, but with a higher percentage of patients undergoing non-invasive ventilation instead of invasive ventilation at admission. French data, as far as I know, are more or less similar. Another thing that I can tell you is that we had to create a very large network of ICUs as I told you, so the principle was we first of all, we thought that it was important to concentrate those patients in units with experience in the treatment of ARDS. After a week, we realized that it was impossible because the 15, 20, let's say, hub units were already full of patients. So we had to, again, as I told you, we had to involve other smaller units with less experience in the treatment of ARDS, and we ended up with something like 90 COVID-19 units in the region. And what is true is that the performance of those units in terms of mortality was certainly different. So we were ranging from like 26, 28% in some units up to more than 70% in other units. So for sure, also experience in the management of those patients is important, but we couldn't do anything different because experience center had not enough beds for every patient.
Good. I will go through another question. How many invasive ventilators you have in your unit?
In my unit, so in my hospital, we started from 20 ICU beds, all with an invasive ventilator, of course. We ended up with 4 different units and 65 ICU beds, all with an invasive ventilator. In some hospitals, they had to use also the ventilators of the operative room, which are okay in the initial phase when patients are sedated and paralyzed. So when you have to apply controlled mechanical ventilation, as you all know, anesthesia machines are not very good in the weaning phase. So when you want to move from controlled ventilation to assisted spontaneous breathing. One thing I can tell you is that there's been a lot of debate around that, but we never had to use one ventilator for 2 patients. So we were ready to do it. We prepared also some dedicated circuits, but we never had to use one ventilator for 2 patients. We certainly had to use, besides ICU ventilators, also operative room ventilators and transport ventilators.
Okay, thank you. So we can also skip the question in regards of the use of one ventilator for different patients. Another question is, did you intubate all patients with respiratory distress?
No, again, we tried to, well, it depends on how you define respiratory distress. Let's say that we tried to give to every patient a chance of non-invasive management of their respiratory failure, and in a certain percentage of them, this attempt was successful. So I'm convinced that in a good percentage of patients, non-invasive ventilation, non-invasive approach, that again in our case consisted mostly of CPAP, and the combination of prone positioning in non-intubated patients helped us to avoid intubation. But when the patients remained severely hypoxemic or had signs of increasing respiratory distress, then yes, we intubated them. What happened due to the overwhelming number of patients and to the difficulty in increasing more the number of ICU beds was that probably we had to delay intubation in some patients that in normal times we would have intubated earlier. But I am convinced that we were able to intubate almost every patient who basically needed intubation and who was a reasonable candidate for intubation, meaning a patient with reasonable chances of surviving and of recovering with a, let's say, acceptable quality of life.
Okay, and a couple of questions in regards of CPAP and non-invasive ventilation. So first, how did you manage to look after the thousands of patients in CPAP NIV that were not admitted to the ICU beds? And more in general, what is your experience about the use of non-invasive ventilation in COVID-19 ICUs?
So how we were able to, again, we as I told you at the beginning, we had to stop all elective surgical procedures. So basically well, in Italy, first of all, in Italy, anesthesiology and intensive care medicine is the same specialty. So we do not have internal medicine doctors or pneumologists or cardiologists in the ICU. We're all anesthesiologists. So basically all the anesthesiologists who had no operative theaters to work on were moved to the ICUs. And we created some rescue teams or medical emergency teams who basically took care of the patients outside the ICU. So we managed those patients together with the pneumologists or cardiologists or infectious disease specialists, and we went to see them at least 2-3 times every day. So we were able to monitor them and to do something like, let's say, a level 2 ICU outside the ICU. Our experience with non-invasive ventilation, again, there is a lot of debate on non-invasive support, respiratory support, in patients with acute hypoxemic respiratory failure, not only with COVID-19. What we know is that patients with acute hypoxemic respiratory failure managed non-invasively have a very high risk of failure. We know that severity of hypoxemia is associated with the risk of failure, and ARDS is associated with a higher risk of failure. This is basically what we know. And this is valid not only for COVID-19, but for any cause of acute hypoxemic respiratory failure, especially pneumonia. In the case of COVID-19, there is also the additional problem of the risk of spread of the infection, especially with face mask or high flow nasal oxygen, because clearly patients, there is a lot of leakage from the mask, or with high flow oxygen, patients can freely cough in the ambient. So there's also the risk of contamination, and this is why one of the reasons why we decided to use the helmet in most patients, because clearly the helmet is more like a closed environment, and you can put an antiviral filter at the inlet and at the outlet of the ports of the helmet. So basically the air which is exhaled by the patient through the PEEP valve is filtered by an antiviral filter. So the only thing you have to take care of is that the antiviral filter adds some resistance. So probably the level of PEEP that you apply is slightly higher when you have the filter compared to that you can read on the PEEP valve. So we used a lot of CPAP, of helmet CPAP. Again, we have been able to put the patients in prone position even during helmet CPAP. Clearly, some patients do not tolerate it, but in some patients we've been able to do it also for a longer periods of time. My experience was that we had an overwhelming number of patients again. So we had to, in some cases, force with non-invasive management of the respiratory failure because we did not have, for example, an ICU bed immediately available. We did not see a failure rate higher than that reported for other cases of hypoxemic respiratory failure. So I think that it's possible, and it has a good rationale to try non-invasive respiratory support in those patients. Clearly, you have to monitor them very closely for signs of distress and the worsening, and you should try to do every effort to avoid any delay in intubation if the patients fail the non-invasive approach. Clearly, this has to be balanced with the available resources, because it's true that only a small percentage of patients need ICU admission. It's also true that this percentage is probably even smaller, because again, we do not know exactly the denominator, the total number of infected patients, but a very small percentage of an incredibly high number still makes a very high absolute number. So it's very important. This is a very important point. Probably the most important lessons we learned is that opening new ICU beds, buying new ventilators, increasing your capacity of ventilating patients is very important for patients who are sick. But the only way to survive a COVID-19 outbreak is to avoid new patients to get sick. So in the end, I think that containment measures have been even more important than our capacity to increase the ICU beds, because if you do not stop the spread of the disease, sooner or later your system will be overwhelmed, no matter how potent, how efficient, and how powerful it is.
Yeah. I would like just to say to everybody that we have a lot of questions, so most probably we will not answer right now to all of them because we only have 4 minutes, but don't be scared. We will go through all of them because all of them are tracked and you will receive the answer afterwards. I believe we have time for one additional question.
Even two, if you want. I mean, for me, I can stay a little longer.
Yeah, okay, but because I have to say we are now having around 50 questions, so it would take another hour. So maybe we have another 1 or 2 questions, and then we will send to you afterwards. Thank you, Giacomo. So the next question would be, if the patients have good compliance, as you showed, in some cases, can you tell why these patients have problems weaning off?
Because probably the main pathophysiological hallmark of the disease is a mismatch, a ventilation perfusion mismatch. They certainly have a very high dead space due to intrapulmonary coagulation. You know that those patients have a high risk of thrombosis, have a hypercoagulable state, and so they have a lot of diffuse microthrombosis in the pulmonary bed, vascular bed, which increases dead space and the ventilation requirement. So compliance is only part of the story, but they need a lot of ventilation, and in the end, if they stay long on the ventilator, also their compliance is certainly going to decrease.
Yes. And we have time for some other questions. Another one is, what are your thoughts on proning in non-ventilated patients?
Yeah, as I told you, we did it a lot. There are also studies published, a couple of research letters published in JAMA. A study was being accepted and is coming out in Lancet Respiratory Medicine, and we also published, we're going to publish a letter in CHEST. It works, means that it's helpful to improve oxygenation as in non-intubated patients, as in intubated patients, sorry. So you will see PF ratio improving in a good percentage of patients. We don't know if this improvement in PF ratio translates into a better outcome of the patients. It's feasible, again, if you do it with nasal high flow or face mask, it's probably easier than if you do it with CPAP. And some patients in respiratory distress, they do not tolerate to stay in prone position. So it's not so easy to do, and it's not so easy to keep the patients in prone position, to keep non-intubated patients in prone position for longer periods. But if you are able to do it, you can see an improvement in oxygenation in I would say almost half of the patients.
Okay, very good. I believe we can have a last question, and then we will come through all the tracked question. The next question would be, was there any documented transmission during non-invasive ventilation or high-frequency O2 therapy? We know that you are using a lot the helmet, as you said, but maybe high flow therapy.
Well, documented, I don't know. I know that we had in Italy, we are having a high number of infections among healthcare workers. I don't know if this is related to the non-invasive respiratory support. I don't think so, because basically most of those workers are, for example, general practitioners. And for example, anesthesiologists got the infections in the very early phases of the disease, of the outbreak. Sorry. So for sure, a patient on nasal high flow or on a face mask carries a higher risk of spreading the disease compared to an intubated patient or to a patient closed in a helmet. But clearly, if you approach the patient with the correct personal protective equipment, meaning a N95, N99 respirator mask, a face shield, a coverall, or an impermeable gown with covering of the head, and with a double 2 pairs of gloves, I think that the risk of getting and if you are properly trained on the use of those PPEs, then the risk of getting the infection is quite low.
Thank you, Giacomo. So I would say, really, we were overwhelmed by questions, so still another 40 or 50. But as said, we will ask Giacomo to be so kind to give a short answer together with me. I will review them for you, and maybe I can send to you the summary, because some questions are repeating themselves, and we will send to you all the questions, so we don't lose any information. Giacomo, thank you again for your time and for your experience. This was really important for all the people connected.
Thank you all. Thanks for inviting me, and have a nice day.
Thank you. Bye to everybody.
Bye.